Hello, everyone. Welcome to Chapter 3 of Healthcare Delivery in the United States. Today, in this chapter, we will discuss the politics of healthcare in the U.S. Here you can see many of the perspectives shared by different segments and political groups across the U.S. Some see the healthcare system as a point of cultural pride or the nation's largest economic sector. Others see it as a moral issue. Some see it as a policy issue. And then others a deeply personal matter. And then finally, some see it as a modern healthcare system that was forged by political choices, which we will review in another recorded lecture. So think about the first thoughts that come to your mind when you think about the US healthcare system. You may have just one of these or several of the ones that are listed here. Politics and policymaking have had a central role in three dimensions of the US system: health infrastructure and how medical services are financed, health insurance, and health disparities. Chapter 3 covers each of these domains from a political viewpoint. At the core of health politics, though, is this important question: is healthcare a right, or should it be treated as any other market good? Some people may take issue with the premise of the question itself. Is the answer maybe yes and yes? It's both. So one answer is that the US system is a patchwork of entitlement benefits and services that may be purchased. So the answer is yes to both of these questions. But that brings up a contradiction, and that a contradiction is the fuel that feeds many of the political battles beneath healthcare policy. So this chapter should demonstrate the influence of politics on policymaking and the overall health system. The contraction of healthcare as both a right and a marketable good really contributes to the status of the US as having the most complicated healthcare system among all the advanced countries. Other countries may lean toward more government-run care or more private-run care. The US includes all of these elements, and as a result can be fragmented. Think of a patient who receives care from multiple institutions, and each of those institutions may have different requirements for payment. The patient's benefits may not even transfer from one institution to the next, and so that's part of that fragmentation. Healthcare in the US can be categorized as including government-provided care, so think of the VA, state and local government-run clinics, also private companies. There is no national health planning. This means that states and large cities, they really monitor their own health systems, providers, and data. And that can contribute to innovation, experimentation. Each state can try new things, but it really makes large-scale planning across the country very difficult. And then also this topic of spending lots of money reminds me of a story. I have a colleague who was on sabbatical in a Central American country, and he was bitten by a dog while he was out jogging. And so he went to the local emergency care center for treatment. He said the hospital was simple, but it was organized and clean. He was seen pretty quickly, given a shot, and patched up. And he was out of there within a couple of hours and paid around $20 for the whole visit. That scenario would never happen in the US, or would likely never happen in the US. Okay, this is figure 3.1, and this provides a summary of how American healthcare dollars are spent. The majority of the spending here is on hospital care. That's that big gray section, 32.7%, followed by home care, and then government public health. So a lot of dollars are spent on very sick patients who often have multiple health needs. Perhaps they're chronic or terminal health needs. They have very limited functioning. These are individuals who need intense care and support at the hospital or at home. A recent report from the National Academy of Medicine explored how healthcare organizations can identify high-need, high-cost patients and implement care models that appropriately address the needs of the population to reduce healthcare spending. So this is a topic with a lot of attention right now. This figure here, this shows that the US is distinctive in how much it spends on healthcare. Some critics say that these rankings do not take into account the heterogeneous population of the US compared to other countries that have more of a homogeneous population, like Switzerland, for example. However, the fact remains that the US still spends almost twice as much as the average country, but with poor outcomes. So not a very good return on investment for the public. Looking into the future, here are trends in spending we are likely to see. Prescription drug increases, higher costs for out-of-pocket care, rising Medicare expenses, and premium hikes. There is really no current policy in place that will prevent these trends from occurring. Healthcare will continue to remain a significant portion of the overall gross domestic product in the US. Here are metrics that experts use to measure the performance of a US healthcare system. There are lots of ways to measure it. We have patient outcomes. Of course, that's at the top of the list. The US does not perform well on metrics like life expectancy, disease incidence, infant mortality, obesity. Then there's access, care process, and administration efficiency. So let's look at administration efficiency. The US system has multiple institutions and plans. And so one of the arguments for a centralized healthcare delivery system is the improvement in administrative efficiency. You would have fewer plans and fewer organizations, fewer institutions. And then finally, equity is another way of measuring performance. This figure summarizes an analysis of all 5 evaluative dimensions by the Commonwealth Fund, which is a global health policy research organization. So the Commonwealth Fund has actually published quite a bit on integrated behavioral health care. They wrote an important report called The Impact of a Behavioral Health Condition on High-Need Adults. Back to the table, notice that the US is ranked near the bottom on almost all the categories, except for care process, where they're ranked in the middle, around 5. But the other categories, the US is ranked toward the bottom. And these are all of the metrics that we looked at in the previous slide. This figure looks at higher costs and poorer results, showing that even though the US spends more money than other countries, the return on investment is not good. Notice how much flatter the US line is compared to other countries. So for example, like Chile or Japan, you can see that the line is much more vertical. Although the US system is not as centralized or anywhere near nationalized like systems in the UK or Europe, the government is still the largest source of health insurance in the US. Other sources of pay include private health insurance plans, individual payers, and private charities. So I've worked in systems where private charities are often the source of funds for clinics treating individuals who are homeless. And charities, they really help to fill the gaps where private and public payers do not contribute enough. Here you can see that private health insurance accounts for 34% of healthcare insurance. You can see that on the right-hand side of the figure. So after insurance, the next biggest source of pay is out of pocket. You can see that on the left-hand side, that 11%. So health insurance covers 75% of payments, and then out of pocket is the next big chunk. And it can be devastating to not have insurance because that means the individual has no one to negotiate on their behalf. That means the healthcare providers can charge maximum prices for uninsured individuals. And for some of you who have worked in clinics, when a patient is checking in for an appointment, one of the first things that they may be asked is how they are going to take care of any outstanding debt at that clinic. Here you can see the influence of politics on the evolution of healthcare in the US. So from the 40s and 50s, President Truman called for universal coverage. President Eisenhower instituted a tax deduction to employers offering health insurance. In the 60s, under President Kennedy, Truman's plan was resurrected but reduced in scope. And then Medicare and Medicaid passed under President Johnson. In 1993, President Clinton designed and began the Children's Health Insurance Program, CHIP, and that is renewed by Congress on a regular basis. So Medicare, Medicaid eventually came to cost a quarter of the entire US federal budget. CHIP covers about 9 million low-income children each year. And like I mentioned, it's renewed on a regular basis. There's bipartisan support for it. Here's some other examples of reform. 2009, President Obama submitted his health insurance expansion plan, known as Obamacare. 2016, President Trump, his campaign was built in part around a promise to eliminate ACA, and portions of the law were dismantled through executive orders and other cutbacks. In 2018, the Congressional Budget Office predicted rising numbers of uninsured people. There are dozens of countries today that have a universal care system, meaning that everyone has access to healthcare in those countries. The US system is in the minority. And as a result, there are significant disparities in the US. Where a person lives, their zip code can sometimes have a bigger impact on their life expectancy than their genetic code. And the US system does not adequately address that disparity. So this is what I was just talking about. This figure by the Virginia Commonwealth University Center on Health and Society shows within the Raleigh-Durham area of North Carolina. So for example, there is an 11-year difference in life expectancy going from one zip code. You can see that zip code 27703. And then if you go to 27617, there's just a significant difference. And they might be about 6 miles apart from each other. Finally, this figure demonstrates which states have opted into Medicaid expansion as of June 2018 and which have not. The lighter colored states have opted into expansion, and these decisions are made by elected officials. There's ongoing tension between liberty and government regulation in debates on public health. Here are some examples. There's tension on alcohol consumption, tobacco, obesity. Society and politicians who represent members of society must make decisions about the role of government in regulating health issues like these right here. There are lobbying groups representing industries that are very invested in the level of regulation the government provides. These are powerful lobbying groups, and they often have an outsized influence on elected officials. That is the end of this lecture. Thank you for watching.